So the first one, talking about the inflammatory from an infectious cause, gives you pyelonephritis. So that's basically inflammation of the kidney. And here's a gross image of what you'll see with pyelonephritis. So you see these little white splotches on this kidney. What kind of necrosis do you think is going on there? Somebody want to? Yes? Caseous, that's a good guess. Because how does caseous necrosis form? So caseous necrosis usually happens with an infection or with some kind of chronic granulomatous disease. So caseous necrosis is really within granulomas. And so there are some people with sarcoidosis who could get granulomas forming in the kidney and get caseous necrosis in there. But let's just say this is run-of-the-mill urinary tract infection that has spread up to the kidneys, and you just have general E. coli causing acute pyelonephritis. So what do bacterial infections normally cause? Liquefactive necrosis, right? So these are pockets of pus. So we're undergoing liquefactive necrosis. Now remember, if it's ischemia or any kind of cell injury that's not bacterial or doesn't have a lot of white blood cells involved, then we would expect coagulative necrosis. But in this case, with pyelonephritis, you see pus, you see those pockets of liquefactive necrosis. Now you can distinguish an inflammatory response to an infectious agent from inflammation due to drugs or metabolic insult by how much of the kidney is affected. So if you see these little punctate spots like this, it's because the bacteria have seeded at different places and then grown up and expanded. So it's like little colonies. You've seen that on Petri dishes in microbiology. And that punctate pattern is representative of pyelonephritis, whereas if it's drug-induced interstitial nephritis, you're going to see more uniform inflammation throughout. So pyelonephritis is actually quite common because the main cause is from a urinary tract infection, which is a frequent occurrence. It can be acute or chronic. So acutely, somebody has a UTI, they don't take care of it quick enough, or the body doesn't clear it quick enough, and it goes up, the bacteria go up the ureters into the kidneys, and you get pyelonephritis. You get on antibiotics, because usually people with pyelonephritis get a really high fever, and they go into the ER. They're feeling terrible. They can't really do much. And it goes away. What do you think would cause chronic pyelonephritis? Any ideas? Yeah.
Maybe if you stop taking antibiotics and it gets worse.
Right, so it could be an acute pyelonephritis that never really resolves and turns into chronic. So an acute infection, maybe you start antibiotics and then you stop. Or you drink a little cranberry juice and then you stop. And so you partially get rid of the bacteria, but not enough, and it keeps growing and it turns into a chronic infection. Or there are some types of viruses that could cause a chronic infection. What else? So acute leading to chronic. The main cause is a blockage. So if you have kidney stones, These are calcium deposits that can form in the bladder of the kidney, and they can lodge in the ureter. And sometimes they kind of lodge and dislodge, lodge and dislodge. Well, what that does is it reduces urinary flow for that kidney. And so bacteria tend to grow when there's not good flow. So flow is one of the main ways your body has to keep the ureteral epithelium free from bacteria. And with kidney stones, you block that flow. And then in children, there's something called vesicular ureteral reflux disease, where the little flap, when the ureters go into the bladder, there's a little flap to prevent backflow, so that urine comes into the bladder, but it can't go back up. If that flap doesn't work, and it's always opening, or it's stuck open, then you get a lot of backflow. And bacteria can get from the bladder up into the ureters, up into the kidney very easily. And so kids who have that tend to get a lot of chronic bacterial infections, and they can actually do surgery to fix that. So that's called VUR, vesicular ureteral reflux disease. Yes? Not as, I mean, this tends to be a congenital abnormality. You're born with this little flap problem. Mostly when adults develop some kind of obstruction, it's either cancer or a kidney stone. Yes?
What was the acronym for VUR?
Vesicular ureteral reflux disease. So almost all of the time, pyelonephritis comes via the ureters. Very rarely will you get a blood infection into the kidneys. If you have a blood infection, you have sepsis and you have other bigger problems. Anybody know what the most common agent? Or you could even just tell me where it might come from. Anybody know? So most common is E. coli, or any of the gram-negatives enteric microorganisms. So it's coming from the GI tract, from your poop. And the bacteria are, your urethra is commonly inhabited by a lot of bacteria. But as long as you have normal urination, that flow continually keeps the bacteria from traveling up and causing bladder, ureteral, or kidney infections. And, sorry, I just started the recording. So I'm going to show you how to break down this idea. So tubulointerstitial diseases can be thought of as inflammatory, or something we call acute tubular necrosis. And the inflammatory diseases are either infectious, so that's pyelonephritis, or we call it toxic, and usually this is drug-induced. In both cases, there's a lot of inflammatory cells present in the interstitium with inflammatory. Acute tubular necrosis is more specifically where the tubule cells themselves die, and this could either be from ischemia or, again, a toxic insult. So the kidneys are very susceptible to drugs and toxins, and it could either directly affect the tubules or it can induce inflammation and affect the whole tubulointerstitial space. So that's bacterial, that's infectious pyelonephritis. And then we have interstitial nephritis caused by other things. Most of the time it will be drugs. So drugs that can affect the nephrons, interstitium or the tubules themselves are NSAIDs. These are non-steroidal anti-inflammatory drugs. Ibuprofen, Aleve are the common NSAIDs that people take. And with chronic use, you can actually set up a chronic inflammatory response. It's a little bit damaging to the tubule cells. And then the other big class of drugs that are really cause tubular interstitial nephritis are antibiotics, especially the synthetic antibiotics. So not very often, people often do have allergic responses to penicillin, but not very often will they have interstitial nephritis. However, the synthetic ones, amoxicillin, gentamicin, they can really often cause kidney damage. And we're not exactly sure the mechanism of it, but a lot of people are sensitive to synthetic drugs, and synthetic drugs in other classes as well. But the antibiotics, because they're so frequently given, are a very frequent cause of interstitial nephritis. Most of the time, if you stop the drug that's causing the kidney failure, the interstitial nephritis will resolve and a person will go back to normal kidney function. So this is going to be diagnosed as a decreased GFR and usually hematuria. So very nonspecific because you get those same symptoms with pyelonephritis, you get the same symptoms with glomerular disease. So that's why renal biopsy in a pathologist's job is to figure out what is the most likely inciting factor to give you these clinical symptoms. Yes?
With the antibiotics, do you have to take them over a long period of time?
No, that's a great question. With NSAIDs, it usually is a long period of time. It's people who are taking ibuprofen daily for weeks or months. But with antibiotics, even a 2-week course can cause this. And then it's typically an allergic reaction. So if you go in and you biopsy somebody who has kidney injury after a course of antibiotics, you're going to see eosinophils in there. So it is acting like a type 1 hypersensitivity. So it's an allergy to that type of antibiotic. And sometimes the person will also develop a rash, so it can be a systemic inflammatory response. And sometimes that person will just have kidney injury and no other symptoms. It's always something to be on the lookout for. So what is a pathologist looking for? So this is a biopsy of a kidney with interstitial nephritis. And you can see here's the glomerulus. Looks relatively normal. We don't see increased membrane. We don't see increased eosinophilia, no edema. But over in the interstitium, there's a lot of inflammatory cells. Whoa, changed my pen. Sorry. Anybody notice some? Oh, question?
How would you cure interstitial nephritis and antibiotics?
Right, so you stop the antibiotic. If the person really needs to be on antibiotic, you can switch them to another type and hope that they, usually the people who respond to one, will have this with one, can do okay on another one. So if you started them on amoxicillin, maybe you put them on penicillin or something, a different type of antibiotic. And then the other thing is just supportive care. So giving them fluids to try to flush through the kidneys. Once the inflammatory reaction dissipates, the kidney will heal on its own. If it's a really extreme case, you might give that person steroids. And so steroids are also a treatment for glomerular disease, immune complex disease, because it's a general immunosuppressant. But steroids aren't a great treat. You try to avoid them if possible. So does anybody notice anything else in this image? You see all the extra inflammatory cells. Anything else look abnormal? Yes? Yeah, that's actually blood. It's a great observation. So right here, in this area, that is blood leaking into the interstitium. And blood will also leak into the tubules, and that's why you get hematuria. So this is blood leaking because of necrotic damage induced by the inflammation. And then the last thing to notice here is that these tubule cells, remember when I was showing you the histology image before and I kind of outlined the cuboid epithelial cells? So here's somewhat of a normal one, but look at the kind of ragged edges here. So that's membrane damage. These cells are dying of necrosis and sloughing off into the urinary space. So the tubule cells themselves are also being damaged. So as that's occurring, you can even see here, you get leakage. You're going to get necrotic debris and blood in the urine. So this is now, that's inflammatory tubulointerstitial nephritis. The other one is acute tubular necrosis, which in the clinic, they usually just call it AKI because it's the most common cause of acute kidney injury. Acute kidney injury, though, can be glomerular, like rapidly progressive glomerulonephritis. It can be drug-induced interstitial nephritis, but most of the time, acute kidney injury is going to be due to acute tubular necrosis. And again, you're going to have both ischemic form, so you could have just a blockage of any of the vessels coming into the kidney. And remember those tubule cells, especially in the ascending loop of Henle. But because the tubule cells are so metabolically active, they're very susceptible to ischemia. And then there's a lot of drugs that get filtered into the urine that are toxic to those cells. So because the epithelial cells of the nephron are constantly exposed to all of the toxins being excreted in the urine, they're more likely to be damaged by any of those toxins. So nephrotoxic acute tubular necrosis is also very common. And why some people get interstitial nephritis versus ATN, we don't exactly understand. It may be that oftentimes acute interstitial nephritis happens kind of downstream. You start with ATN and then it gets worse and worse and more inflammatory response comes in. But it's a little bit hard to predict who's going to respond to drugs in which way until suddenly their kidneys shut down. And this gives you just a little bit of mechanism for how this occurs. So I encourage you to trace through this when you're trying to understand acute tubular necrosis. I'm trying to move fast so we get into the liver. Are there any questions? Okay. So just really quick, chronic kidney disease. I think I mentioned this at the beginning of last time. The main causes are going to be hypertension. And hypertension causes, it's a risk factor for atherosclerosis because it causes endothelial damage. But it also causes arteriosclerosis. And what this is scarring of the vessel walls, normally in smaller vessels. Atherosclerosis is usually in larger arteries. Arteriosclerosis is in the arterioles. So they respond to that high wall stress from high blood pressure by just increasing the amount of scar and fibrosis around the wall itself. And as those arteries harden, remember how the afferent and efferent arterioles are really important for controlling the blood flow and filtration in the glomerulus. So that hardening limits your ability to control that flow. So that over time, as more and more arterioles get scarred, can lead to decreased GFR. You have decreased blood flowing through the glomeruli, decreased filtration, which is decreased glomerular filtration rate and long-term kidney failure. Another big one is diabetes. Often, people will have diabetes and hypertension together, as you'll see on Tuesday when we talk about metabolic syndrome. But diabetes itself, just chronic high blood sugar, damages arteries. It also is damaging to the tubule cells, because that blood sugar is filtered out and then reabsorbed. And when that happens over and over again, it actually can damage those tubule cells. And then I talked about there's polycystic disease. And then there can be chronic interstitial nephritis. For example, somebody who's taking chronic ibuprofen for, say they have osteoarthritis or something, they're taking chronic doses of NSAIDs, that can lead to that. And the clinical manifestations are basically a progressive decrease in GFR. So normally you're not going to see hematuria. You're not going to see a lot of proteinuria. It's not as much damage leaking of the glomerulus as just that loss of filtration capacity. Yes?
So someone who has, for example, like arthritis and the doctor tells them a lot of mindset, would you just do like routine blood work every year to figure out how their kidneys are doing, and what is your preventative diagnosis?
Right, so if people are on any kind of chronic drug, you want to monitor them, and it kind of depends on the health of the individual overall as to how frequently you're going to do blood work. For somebody with osteoarthritis, it tends to happen in the elderly. They should be getting annual exams, and a urinalysis is part of an annual exam. Urinalysis doesn't necessarily give you GFR, but it can give you some indications of whether you should do more extensive testing. Blood work, whenever you get a metabolic panel, that usually includes BUN and creatinine, so it gives you an estimate of kidney function. And then, of course, if a person is having any kind of symptoms, like oliguria or hematuria. All right. Here's just a quick example of what I was talking about with diabetes. So it can cause glomerular sclerosis. It can cause arteriosclerosis. So here's an artery that's hardened. Here's the glomeruli that's kind of scar tissue. Sclerosis has overtaken the majority of that glomerular space. And here is tubular injury that's been caused by chronic exposure to high blood sugar or high sugar in the urine, and it causes this fibrosis around the tubules. All right, so let's move on to liver disease. Any last questions about kidneys? Okay. So let's start out with a quick question. What's the function of the liver? I'll give you just 30 seconds to think about it. Okay, let's go through them one by one. Synthesis of protein, yes or no? Does the liver synthesize any proteins? Yeah, this is actually a really important function of the liver. Now, remember when we talked about inflammation? What's synthesized by the liver that's involved in inflammation? Complement. What else? Coagulation factors. So all of those coagulation factors that lead to blood clotting, that lead to activation of fibrin, thrombin, and platelets are synthesized by the liver, and then they circulate in the blood. Albumin. So albumin is a protein found in the blood that serves as a carrier, largely for calcium, but also for hormones and a bunch of other things. It's the most prevalent protein in the blood, and it's the main source of osmotic pressure in the blood. So if you don't synthesize enough albumin, what do you think is going to happen? Besides any metabolic derangements. Just like somebody with nephrotic syndrome, you're going to swell up. You've lost that osmotic pressure to hold water in the blood. And so the water is going to leak into the interstitial fluid, and the person will get swelling. So again, albumin is very important. If you lose it because your liver's not working, you'll get swelling. If you lose it because of massive proteinuria due to glomerular damage, then you'll also get massive swelling from that. And then there's a lot of other proteins that are also synthesized by the liver. Other ones, LDL and HDL. Have you guys heard of those? You've probably heard of them as cholesterol, right? So they're not actually cholesterol. These are massive apolipoproteins. It actually stands for low-density lipoprotein and high-density lipoprotein. So these apolipoproteins mix with phospholipids and cholesterol and triglycerides to shuttle fat and cholesterol around the body. But those apolipoproteins that form the HDL and LDL particles are synthesized in the liver as well. Storage of lipids, yes or no? Yes. This is the primary reason we get fatty change with any kind of hepatocyte damage in the liver. So the liver stores glycogen and it stores lipids. It's one of the biggest fuel sources for the body. And you'll probably remember that glycogen cycle when your muscles run out of energy and you use up all your glycogen stores, and that mobilizes the liver to start releasing fatty acids into the blood so they go to the muscles. Do you guys remember all of that from physiology? Kind of. Yeah, so storage of lipids and energy metabolism are a big function of the liver. Detoxification of blood? Yes, right? That was why all of our portal blood goes through the liver. It's called first-pass metabolism. All of your food and drugs that you take orally, they go first through the liver before they get pumped to the rest of the body. And that's to detoxify anything that shouldn't be there. It's to metabolize a lot of vitamins and minerals that come in a pro form, and then they have to be metabolized into an active form, and that happens in the liver. I already mentioned storage of glycogen. Those kind of are interrelated. What about synthesis of bile? Yes, right? So the gallbladder stores bile, but the synthesis of bile happens by hepatocytes in the liver. So the liver has a big job. Yes?
On the quiz, we answered true the first time, or false, because it said sole reason is produced bile.
Right.
It's false, but the correct answer was true.
Was it? I'll have to go back and look at that.
That's great, we just wanted
The benefit of having two. Yeah, if you catch mistakes like that, because clearly the sole job of the liver is not just synthesis of bile. It does a lot of other things. Please email me and let me know, because oftentimes I just forget to click the right answer on the quiz. Yes, these are all important functions of the liver. So quick review of what the liver looks like. Remember that the liver is divided into lobules, and each lobule is an area of hepatocytes like this that surround a central vein. The central vein carries blood back to the inferior vena cava to go back into circulation. And around the lobule, so this is kind of a picture of a lobule here. Here's the central vein. And on the outside of each lobule are the portal triad, which consists of the portal vein. Remember, the portal vein is carrying blood from the digestive tract into the liver. You have the hepatic artery. And the hepatic artery is bringing fresh blood from the abdominal aorta going into the kidney to oxygenate the hepatocytes. So you have two blood supplies coming into the liver simultaneously. Oxygenated blood, which is there to give nutrients to the blood, and then the portal venous blood, which is there for the detoxification process. And then you also have your bile duct. So blood is coming in here, and it's traveling this way, and it's all going to go out the central vein. Whereas bile is being made by these hepatocytes, and it's flowing the other direction through the caniculi into the bile duct. And then those bile ducts all go and drain into the gallbladder and into the small intestine. So when you're looking here, these kind of uniform purpley pink cells, those are all hepatocytes. The liver is very homogeneous, and they're depicted over here. Other than your veins, you just have tons of these hepatocytes. So, thinking back, we've learned a little bit about the liver before. What is the regenerative capacity of the liver? High or low? High. And why? What factors go into that? What's that? They're stable cells, right? Which means that they aren't always dividing, but they still have the capacity to divide it when needed. So they still have proliferative capacity. And the proliferative capacity of hepatocytes is actually really large. As long as the architecture of the extracellular matrix is intact, you can damage up to 90% of your liver and still have full regeneration. So it's really amazing. People don't usually die of acute liver dysfunction. We have such amazing capacity for regeneration. And then, thinking back to when we talked about patterns of injury of cells, what do hepatocytes look like when they're injured? What do you expect to see? So you might see inflammatory cells if there's an inciting factor, but what if it's ischemia or a drug causing injury? So scarring is if there's a chronic process. Yep. Yes. So yes, hepatocytes will change shape. What exactly? It'll definitely swell. So swelling is a big. And then remember that we saw fatty change. So hepatocytes that are injured show fatty change. And that's pretty unique to the liver. Cardiomyocytes, to some extent, will show a little bit of fatty change, but the liver is really, if those hepatocytes are injured, you get a lot of fatty change. And I don't remember, get to it in just a second. So the fatty change that's going on in the liver is an accumulation of triglycerides. And it's thought that there's two mechanisms or two reasons, or there's probably a lot of reasons. It's not completely, the pathophysiology isn't completely understood, but one reason that this happens is that the hepatocytes are responding to damage. Normally, they store triglycerides and for later. And so if the hepatocytes are damaged, they can't get those triglycerides out. They don't end up shuttling them out of the body anymore. They keep them inside because they don't have the mechanism to export it. Normally, triglycerides are exported by LDL and VLDL. Low-density lipoprotein and very low-density lipoprotein. Again, these are synthesized by the liver as that synthetic capacity goes down because hepatocytes are damaged. And probably other mechanisms that aren't fully worked out, you just don't shuttle that cholesterol and triglyceride out of the cells anymore, so it accumulates in the cells. The other main reason that it accumulates is that, going back to the different things that happen with cell injury, mitochondrial damage is a big one, and then another big one is a loss of oxidative phosphorylation. And those are related because that's where the mitochondria do oxidative phosphorylation. But in hepatocytes hepatocytes in general, they mostly use triglycerides or fatty acids as their fuel source. They do metabolism by beta oxidation, which is where fatty acids, those long carbon chains, are broken down and fed directly into the Krebs cycle, rather than using glucose as a primary fuel source. So they use a lot of fatty acids, and if the cell is damaged, it's not able to oxidize those fatty acids as well, and so they accumulate. So that's just two of the mechanisms by which fatty change probably occurs. I put a picture of that. And I wanted to show you here, this is a VLDL particle, just to give you an idea of what I was talking about with the shuttling. So VLDL is actually, we call them particles because it's not just one molecule or one substance. It's made up of lipoproteins. It's made up of triglycerides in the center. And then the shell of it is phospholipids and cholesterol embedded in there. And then you can get some cholesterol in the center. So one of the jobs of the liver is to send triglycerides out to the body when it's needed as a fuel source or for normal wear and tear. Like, you have to regenerate membranes all the time. Cholesterol is an important part of your membranes. So it's to shuttle this stuff out of the liver. It stores it in the liver until it's needed. It shuttles it out into the body. And then VLDL and LDL. So they shuttle triglycerides and cholesterol away from the liver. And then HDL brings it back. Which one is your good cholesterol? HDL. So when you get your cholesterol, you get it broken down into LDL and HDL. And it used to be that they said cholesterol of 240 is high cholesterol, hypercholesterolemia, and that's bad. But now they actually want to see the ratio, because if your cholesterol is high, but you have a high HDL, that's actually protective. It's not as bad as if you have high cholesterol, but most of it is VLDL and LDL. So this is quote-unquote good cholesterol. Because what HDL is doing is it's taking excess cholesterol from the body. And remember, atherosclerosis tends to be a buildup of cholesterol in the arterial wall. So HDL helps to take that cholesterol that's not needed back to the liver, and then you can excrete it through the bile and eliminate it from the body. So high HDL is actually considered a good protective factor. So let's look at acute versus chronic liver disease. Acute liver disease is not very common. And that's because you can sustain quite a bit of liver damage before you actually get any kind of symptoms. And the liver, as long as that damage is acute, the liver can regenerate. The main causes of fulminant acute hepatitis, which is basically just massive liver damage leading to liver failure, are drug overdose, and then viral hepatitis. Those are the two most common reasons somebody would acutely die of liver failure. And what you see is you see massive necrosis. So Tylenol is the prototypic drug overdose. You have to take a whole bottle of Tylenol to really die from overdose. And what it does is it builds up. Your Tylenol is metabolized in the liver, and as that metabolism happens, it uses up the enzyme in the liver that combats oxidative stress. So you use up glucuronidase, I think it's called, so that now the liver is highly exposed and susceptible to reactive oxygen species, which are generated all the time as natural part of oxidative phosphorylation. And so you get massive necrosis due to oxidative stress. And you can see here, these cells, a lot of them have lost their nuclei. There are a few, these purple dots are inflammatory cells. There's a lot of swelling. So over here, the cells haven't fully undergone necrosis yet, but you can still see they're starting to shrink, and there's edema in between them, and most of them have lost their nuclei. So this is widespread necrosis. There isn't usually time for fatty change. So the cells are so damaged that they just start to die right away. With viral hepatitis, you see an inflammatory response. What kind of cells do you think these are? We're talking about a viral infection. I think I heard it over here. Someone said T cells. So remember, your cytotoxic T cells are responsible for killing virally infected cells. So you have a massive influx of T cells. And here you can see up here, these are still relatively normal cells. So again, viral hepatitis, acute viral hepatitis usually is not deadly. And most people will get through it with just supportive care, meaning that as long as they stay hydrated in the hospital, all of this normal liver over here is going to regenerate as soon as this infected liver has been necrosed and eaten away, basically. So now let's look at chronic liver dysfunction. Here you see fatty liver disease. So there's two main causes of fatty liver disease: alcohol, and this is long-term chronic alcohol use, or obesity/metabolic syndrome. Alcoholism used to be the main cause of fatty liver disease. Now with that, obesity is on the rise in the United States and around the world. That has taken over as the most common cause of fatty liver. Other causes that are a little bit less common. You can still get viral hepatitis. Any kind of cholestasis, which is blockage of the bile ducts. And then you can also have chronic drug or chronic toxicity. And again, the main things you'll see are fatty change, which I already mentioned the mechanism for that. And then as that progresses, fatty change, irreversible or reversible? Reversible, yes. So fatty change is an early sign of hepatocyte injury, but it's still completely reversible. So if increased adipose tissue is the cause, and a person loses weight and starts eating healthier, fatty liver disease will completely reverse itself and go back to normal. If you have an alcoholic, somebody who's been using alcohol just for maybe 10 years, or binge drinking actually can cause fatty liver disease after just one massive influx of alcohol. But as long as you don't keep doing it, that can be reversed. If you stop alcohol use, it can be reversed. Viral hepatitis also, same thing. Is if the body can clear the infection before it causes scarring, then you can reverse that disease. In this image right here, you see some fatty change, but this is actually chronic viral hepatitis, and it's gone on to start scarring. So I'm not sure if you can see it too well, but right along here, these are called septae. So these are bands around the lobules that are the first to fibrose. So you're getting a little bit of fibrosis in these septae. So here, this would be a portal triad, and the fibrosis starts in there because that's where a lot of the fibroblast cells of the liver live, and that it extends around. And what you'll see is these fibrotic bands start to surround liver tissue as it's going through the repair process. So this is called a regenerative nodule. So this is liver tissue actively trying to repair itself. The hepatocytes are dividing within, but it's surrounded by a fibrotic band. Now let's see what happens if that chronic injury keeps going. You get to cirrhosis, which is really an end-stage liver disease. Cirrhosis is not easily reversed. Early scarring, there's still some remodeling, those regenerative nodules, that you can reverse early stages of cirrhosis, but once it gets to the point where most of the liver has been scarred over, you've damaged the extracellular matrix and the liver cannot regenerate. So what you can see here, this gross image of the liver is showing all of these nodules. So if you feel it on physical exam, you can actually feel the nodularity. It's a hard liver with hard little nodules. Those nodules are fibrotic bands around these little islands of regeneration. Here's a close-up of it. So this is the fibrosis all around here, and here's a little island of hepatocytes. You can see that they're still trying. They're trying to have the acinar appearance. But again, a lot of the liver tissue is taken over by scar, and that's not reversible. Yes?
So the bands that are wrapped around those regeneration nodules, is that what prevents it from healing?
Yes. Yeah, so what these bands are made of, this is extracellular matrix. This is fibrin, mostly collagen. But if that scarring, if you get too much deposition of these extracellular matrix proteins without preserving the normal architecture, So normally they provide a nice scaffold for the hepatocytes to form those acini. And if the scar tissue is just too dense, it ruins that scaffold. And once the scaffold is destroyed, you can't regenerate in that space. And so cirrhosis is basically where scar overtakes all of the extracellular matrix and eventually all of the functional capacity of the liver disappears. So here are the clinical signs of liver disease. And this is true for cirrhosis no matter what the cause, whether it's viral, it can be caused liver damage by cancer, or eventually if fatty change due to alcoholism is not reversed, you'll get cirrhosis. No matter what the cause is, as the liver doesn't work anymore, these are all going to be your causes. So you all know what jaundice is? Right, the yellowing of the skin. The first place to look for yellowing is in the eye. Encephalopathy. This is basically brain damage. We don't fully understand how encephalopathy is caused by the liver, but because the liver is basically detoxifying, the metabolic byproducts that aren't eliminated seem to be toxic to the neurons. And clinically, one of the first signs, if you ever have somebody who comes in with cirrhosis, you can ask them to hold their hands out and put their palms up like this, and you'll see them go like they flap. So their cerebellum is damaged, and they can't hold their hands up anymore. So that's one of the earliest neurologic signs that somebody is is heading towards liver failure. Beyond that, you're going to start to see confusion, and eventually a person can go into a coma. Anybody know what ascites is? Yeah, it's this. It's accumulation of fluid in the abdominal cavity. Bleeding, we already saw the esophageal varices. So one reason that people with cirrhosis will have bleeding is because they have these high pressure veins. That veins have really thin walls, so they easily can rupture, and that can cause massive bleeding. What's another reason you might get bleeding? Related to the function of the liver. So you have decrease.
Decreases the pressure on the
What's that? Oh, so along those lines. So it's not albumin, but if you decrease making proteins, including the clotting factors, the albumin, decreased albumin, and increased portal pressure is what leads to ascites. Decreased synthesis of clotting factors is what leads to bleeding, in addition to the portal hypertension and the varices. And then for all of you men who like to drink, watch out, because one of the most disturbing symptoms to many people is you get gynecomastia and hypogonadism. So in men, their testes shrink and they get boobs. And it's because one of the roles of the liver is to metabolize estrogen. So changing estrogen into testosterone requires the liver to be functional, and when that function goes away, you get hyperestrogenemia, hyperestrogen levels, and that has severe symptoms in both men and women, but they're more clinically apparent in men. So another thing you see right here with is, I just wanted to point this out because it's good to recognize these veins are also varices. So the esophageal varices that develop with portal hypertension, I put a slide on that. Okay, we're going to skip that really quick. Here we go. So as your liver becomes scarred over and you get increased pressure in the portal system, that pressure backs up, and so some of the veins in the esophagus become distended. The spleen can become enlarged. It becomes engorged. The rectum, there's a lot of collateral blood flow through the veins of the rectum, and so hemorrhoids are really common in portal hypertension caused by cirrhosis. And then the last one is you get varices around the belly button. So there's some veins from the gastric venous system that anastomose with the portal venous system. And as those veins distend, you can actually see them